Hey everyone, I am absolutely thrilled you're joining us today. In this explainer, we're embarking on a really important journey, demystifying the foundation of multiple sclerosis, or MS. Look, whether you or a loved one has recently been diagnosed, or you're just trying to wrap your head around the science behind this condition, you are in the exact right place. Our goal today is to build a rock-solid, incredibly clear understanding of what MS actually is, how it behaves, and exactly how doctors identify it. And don't worry, once we lay this groundwork, we're going to be tackling everything you need to know about MS treatments in our very next explainer.
To get us there, we've got a really clear roadmap for today. We'll cover understanding multiple sclerosis, who gets it and why, spotting the symptoms, the different MS types, and finally, getting a diagnosis. Okay, let's dive right into this.
Section 1. Understanding multiple sclerosis.
At its core, an MS diagnosis can feel incredibly overwhelming, right? But I want you to think of it as a complex, yet entirely understandable puzzle. It's a puzzle that researchers and doctors have been meticulously piecing together for decades. And honestly, we have a clearer picture of it today than ever before. The very first piece of that puzzle is a word you're going to hear a lot: demyelination. See, MS is an immune-mediated inflammatory disease of the central nervous system, which basically means the body's immune system mistakenly targets the brain and spinal cord. Think about a typical electrical wire in your house. You've got a metal core to conduct the signal and a rubber coating on the outside to protect it. Well, in your central nervous system, your nerve fibers are the wire, and they're coated in a protective insulation called the myelin sheath. In MS, inflammation damages that myelin. So when that insulation gets frayed or destroyed, that's the demyelination process. The electrical signals your brain is trying to send can short-circuit, slow down, or just stop altogether. Moving on to Section 2. Who gets it and why?
If you're navigating an MS diagnosis right now, I really want to validate your experience. You are not alone in this. You're part of a widely studied, globally recognized community, and medical science is hyper-focused on the epidemiology behind it. When we look at the data, a pretty clear pattern emerges. It primarily affects young adults. In fact, aside from physical trauma, it's actually the most frequent cause of permanent disability in that younger demographic. Also, MS affects females significantly more often than males, and over the last several decades, studies show that female-to-male incidence ratio is steadily going up. It's currently sitting at about 2.3 to 1. Researchers are actively investigating why this gap is widening, digging into everything from environmental factors to urbanization.
Now, what's really interesting here is the geography, because MS doesn't impact the globe evenly. In the United States, the prevalence is about 309 cases per 100,000 people. To put that into perspective, that means there are roughly 725,000 people in the US alone navigating this exact same condition alongside you. But statistically, your risk actually drops the closer you get to the equator. It creates this very distinct north to south geographic gradient. So high-frequency areas tend to be the northern parts of the US, Canada, and Europe.
Section 3. Spotting the symptoms.
So we know what MS is structurally and who it tends to affect, but how does it actually feel? Well, MS is famous for producing what we call invisible symptoms, things you feel intensely, but a casual observer might never even notice. Interestingly, this symptom story often starts long before a formal diagnosis is ever made. Medical science has identified a relatively new concept called prodromal MS. This tells us that a full 5 to 10 years before the classic, recognizable signs of MS ever appear, people often experience a wave of early nonspecific health changes. We're talking worsening mental health, subtle drops in cognitive performance, or just a generally increased need for healthcare visits. It's basically the body quietly signaling that something is shifting years before the central nervous system inflammation becomes totally obvious.
When the classic symptoms do finally arrive, they can be all over the map because they depend entirely on which part of the brain or spinal cord is actually experiencing that demyelination we just talked about. Notice the breakdown here. Sensory issues in the limbs, like numbness or tingling, are the absolute most common initial presentation, affecting about 31% of patients. Another huge hallmark is optic neuritis, which is vision loss in one eye, often paired with pain when you move the eye. That affects about 16%. If you've ever experienced sudden weakness or double vision, known as diplopia, this data perfectly validates your lived experience. These are textbook clinical presentations.
Now, because MS can mimic so many other issues, neurologists have to act like detectives, looking for highly specific clues. They're constantly contrasting suggestive features with atypical features. For instance, a classic suggestive feature is the Lemaitre sign. This is an intense, electric shock-like sensation that shoots down your back and limbs when you bend your neck forward. Or there's the Uthoff phenomenon, where symptoms temporarily flare up in the heat. On the flip side, if someone presents with early dementia or rigid muscle dystonia, doctors consider those atypical features, and that usually prompts them to investigate diseases other than MS.
Let's move to Section 4 and see how this builds. The different MS types.
Symptoms tell us what's happening right now in the moment, but the MS type tells us how the disease behaves and progresses over a whole lifetime. The journey usually kicks off with something called clinically isolated syndrome, or CIS. You can think of this as the precursor to MS. It's defined as the very first monophasic clinical episode, basically a single attack of demyelination that lasts for at least 24 hours. For most people, this is the very first time they realize, hey, something is wrong. Now, having CIS doesn't 100% guarantee you'll develop long-term MS, but if future tests reveal more lesions over time, that CIS is reclassified as the official start of your MS journey.
If someone is definitively diagnosed with MS, they'll most likely fall into this category: relapsing remitting MS, or RRMS. This accounts for a massive 85 to 90% of cases right at the onset. Notice the distinct pattern. You get these sharp peaks, which are the active relapses or flare-ups where symptoms suddenly peak over a few days or weeks. But then, and this is crucial, they are followed by periods of remission. The symptoms partially or even fully resolve, and the disease just remains stable without active progression for a while.
However, the disease course can evolve. Over time, usually years or decades, relapsing remitting MS can transition into what we call secondary progressive MS. In this phase, the whole pattern shifts. Instead of having those clear relapses followed by quiet recovery periods, the neurologic disability begins to gradually and steadily worsen on its own. It happens largely independently of any acute relapses. It's basically a transition from an inflammatory focus to more of a gradual neurodegenerative process. Now, contrast those first two types with primary progressive MS, or PPMS, which affects about 10% of patients. See the difference? There is absolutely no initial relapsing remitting phase here. From the very onset of the disease, there's a steady, insidious accumulation of disability. You might see occasional temporary plateaus, but the overall trajectory is a gradual worsening from day one. It actually often presents first as a progressive difficulty with walking.
Section 5. Getting a diagnosis.
It's totally normal to feel anxious about how doctors can possibly pin down exactly what's happening in your nervous system. But I want to assure you, diagnosing multiple sclerosis is a highly rigorous, evidence-based, and heavily standardized process. It relies on the recently updated 2024 McDonald's criteria. The whole philosophy here is proving two things: that damage has occurred in different parts of the central nervous system, we call that dissemination in space, and that the damage occurred at different points in time, dissemination in time. Neurologists combine your objective clinical exams, advanced MRI scans, and sometimes spinal fluid analysis to definitively lock in those two crucial elements.
And this brilliantly illustrates exactly what we mean by making the invisible visible. This is exactly what your doctor is looking for. On an MRI, MS shows up as distinct white matter lesions. You can actually see active inflammation taking place, which lights up brightly when a contrast dye like gadolinium is used. We can also spot older, permanent damage, sometimes referred to as black holes. Seeing both active enhancing lesions and older non-enhancing lesions on a single scan is basically a fast track to proving that the disease has been active at multiple different times.
Sometimes, though, the MRI and clinical history just aren't quite enough to make a definitive call. That's when doctors utilize ancillary testing, most notably a lumbar puncture, to analyze the cerebral spinal fluid. They're specifically looking for unique immune system markers, things like oligoclonal bands or elevated kappa-free light chains. If those are present in the spinal fluid, it essentially proves chronic inflammation in the nervous system. And under the modern criteria, finding these markers can actually fulfill that dissemination in time requirement. That allows the doctor to diagnose MS even if you've only ever experienced one single clinical attack.
So, the crucial point is this: achieving an accurate, evidence-based diagnosis is a monumental milestone, but it's just the foundation. It's the starting line of your roadmap, definitely not the end. The very next question, and rightly so, is always about action. What do we do now? How do we fight back?
Well, that is exactly what we're going to cover in our next explainer. We're going to dive deep into how doctors treat acute flare-ups, and most importantly, we'll explore the incredible advancements in disease-modifying therapies. Modern science is literally rewriting the prognosis for MS as we speak. So,
Take a moment to digest what we've learned today and take a deep breath. Because if we can now spot MS years before the first clinical attack, just imagine what modern therapies can do to stop it in its tracks. I'll see you in our next explainer to talk about taking back control.